Good morning. I'm Mr. Aslam. I'm an orthopaedic consultant surgeon specializing in robotic surgery. We're going to talk today about hip osteoarthritis and hip replacement surgery. The hip joint is a relatively simple joint compared to the knee. It essentially consists of a ball, which is the femoral head. Here we can see we've got a thigh bone and we've got the femoral head on top, and it consists of a socket, which is a part of the pelvis. Right, so we can look at the pelvis. The pelvis is a structure which consists of three bones, essentially the iliac bone, two of those, and then we've got at the back, we've got the sacrum, which is known as the sacrum that is attached by the sacroiliac joints, and at the front, the pelvis is attached by the pubis. So the actual iliac bone consists of the iliac wing, it consists of the pubic rami, and it consists of the ischial tuberosity. And those aspects come together and they form the hip joint. Now, we know that the hip joint consists of an articulation between the bone and the femoral component, which is known as a ball and socket joint. There's a 4mm coating on the socket, a 4mm coating on the head, and as that coating starts to wear down, you're going to get bone on bone, which is going to produce pain. So hip pain can present depending where the damage is. If the damage is at the top of the hip, it's going to cause groin pain. If the damage is on the central part of the bone, it's going to cause pain in the buttock. If the damage is at the back of the hip, it can cause pain deep in the buttock. And there's a percentage of people who are going to get referred pain from the hip going down into the knee. So the pain may go into the side of the hip, the thigh, or it may even be totally in the knee joint. And it's not uncommon that we see people who have knee pain, but the predominant problem is in the hip. So the surgeon has to be careful at treating the right joint. Once that arthritic process starts to get worse, you get exposed bone, which rubs on exposed bone, and the hip will start to stiffen up. So what patients will find is that the movement will start to reduce. So what patients will find is the movement will start to reduce. So they'll get limitations in bend, and more importantly, the rotation will start to limit. And one of the first findings in hip arthritis is that the hip will lose its internal rotation. So it still has external rotation, but it'll lose the ability to internally rotate as the capsule starts to contract. And this means that patients will find it difficult to put shoes and socks on, they'll have difficulty in walking, they'll start to limp, and they'll start to have pain at night. When you start to have the pain at night, that's when the quality of life and the symptoms take on different meaning for patients. So the symptoms of a arthritic hip would be pain which can be in the groin, it can be in the buttock, it can be in the thigh or the knee or a combination. Patients will be limping. They will have noticed a change in the direction of their foot. It tends to turn out. They will not be able to put their shoes and socks on. They'll find it difficult to get out of a chair, into a car, and the walking becomes more and more limited. Eventually, they will have pain both at rest and at night, and walking is very limited. And that's when we'll start to discuss the options of treatment. With all these conditions, there's a conservative plan which would involve pain management initially with simple painkillers, anti-inflammatories, and physiotherapy, which is important as it will strengthen the muscles around the hip. Even if you're having surgery, you would like to have strengthening around the hip, which will improve your recovery rates. Injections in the hip are possible. There is some evidence that they can cause more damage, so we have to be careful. Generally speaking, if we have patients who are unfit for surgery or who are not clear where the pain is coming from, we can inject the hip as a diagnostic and therapeutic step. We can also inject younger patients if they don't want to have surgery. Eventually, patients will reach a stage that we're heading towards surgical treatment, and that operation, in most cases, will be a hip replacement. So in a hip replacement, what we do is we approach the hip and we cut the bone here and remove the femoral head. Now, the approach to the hip varies depending on which surgeon you go to. Some surgeons make a 20, 30 centimeter incision and they dislocate the hip and they release all the structures, and then they'll do the hip replacement and put it all back, which is conventional teaching and is absolutely fine. We ourselves prefer to preserve the muscles and minimize soft tissue damage. So we prefer to do minimally invasive surgery, which is a smaller incision. So we go from here to here. We cut the hip in position, so we're not dislocating the hip totally out. We cut the hip in position and we remove the head with a corkscrew, and that minimizes the stretching and damage to the soft tissues. Then we effectively do the operation, and we keep most of the structures intact and do minimal bone reaming.